Good afternoon, everybody. This is Stephanie Hall, and I'm with the ESRD NCC National Coordinating Center. Thank you for joining us today for the NCC Professional COVID-19 Educational Webinar event. As you know, these events are being held in partnership with the Centers for Medicare and Medicaid Services. The series of events feature guest speakers from around the country sharing how they or their organizations they are with are coping with COVID-19. Before we get started, I wanted to let you know that this call is being recorded and will be posted to the NCC COVID webpage within 3 business days. Next slide. So let's just go a little bit over the agenda. We talked about a little bit what the call will be about today. We have Dr. Millson, Director of Infection Prevention from George Washington University Hospital, as our presenter. The topic today will be avoiding COVID complacency. And even though all the attendees are muted upon entry into this event, we do want to hear from you. So during the presentation today or at the conclusion, if you have questions, please submit them through the Q&A or the chat features, and we will get through as many questions as we can at the end of the presentation. Next slide. So if you've been on these calls before, you know we have these bi-monthly professional COVID webinars. They're on various topics. You always hear from stakeholders and peers in the ESRD community who are adapting to COVID-19. They share examples and provide real-world strategies for facilities to use. Next slide. So we'll go ahead and get into our presentation today, and let me introduce our speaker. Like I said, it's Dr. Tara Millson. She is the Director of Infection Prevention at the George Washington University Hospital in Washington, D.C. Dr. Millson has extensive clinical experience in nursing and infection prevention in acute care and hemodialysis settings, as well as experience in public health surveillance at the CDC in Atlanta. Dr. Millson is active with several professional organizations, serving as Vice Chair for the Practice Guidance Committee for the National Association for Professionals in Infection Control and Epidemiology, and serving on the Guidelines Committee of the Society for Healthcare Epidemiology of America. So we're pleased to have Dr. Wilson with us today. Dr. Wilson?
Thanks, Stephanie.
Thank you.
Can you hear me okay then?
Yes, and you have the ball too.
I do, yes, thank you. All right, thank you, and welcome everybody. I'm really pleased to have so many participants here to talk about this really important topic and timely topic at this stage of our global pandemic. Today I'm going to talk to you about why we need to stay vigilant, even though it is so hard a year out of this pandemic, but why we need to continue to do that. And exactly what complacency is and how we can notice signs of complacency both in ourselves and in others, people that we live or work with, and talk about some measures that we can use to maintain those preventive and protective focus that we were so focused on about a year ago during this stage of the pandemic. Just a quick review of COVID. It's a terrible disease, but we have made some tremendous scientific achievements over the past year. In 1 year, globally, we have been able to characterize a new illness that nobody had ever heard of 15 months ago. We sequenced a new genome. We developed diagnostic testing. We created treatment protocols. The mortality rate has decreased tremendously from our treatments that we have available now that we didn't have a year ago. We've also been able to establish the efficacy of medications in treating this disease, and most incredibly, we've been able to produce vaccines, which are now widely being given to people across the globe. Despite as much as we've learned, we still have so much that we do not know. We don't know if COVID is going to become endemic, if this is something that we're going to be seeing all over the place. We don't know if it's possible to get reinfected. There's some data that suggests that this may be possible. We don't know if the vaccine that's currently available will protect us against the variants that are also starting to circulate. We also don't know how long the immune response will last. Right now, we know for about 90 days that people have a pretty predictable amount of antibodies, but beyond that, we don't really know, so we're still learning. And then there's also a group of patients being referred to as long haulers, and these are people who had COVID, and long after the symptoms should have resolved, they're still experiencing symptoms, some people for many months. We also don't know if COVID is going to be seasonal. You know, we see that with influenza. We get influenza every year. We have different strains every year. We have to get vaccinated every year. Is this going to be the case with COVID? And it's just too early to know that. And then we also don't know how immunity may vary based on different demographic information. So COVID-19 is important when we're talking about patients with kidney disease because it's disproportionately severe for patients that are on dialysis. They have about 18 times higher risk of hospitalization and death from COVID-19 than patients who don't have end-stage renal disease. And the mortality rate is as high as 20%. And this is compared to the general population where it's less than 5%. Also, this population is unable to shelter at home, right? They have to leave their house 3 times a week to go get their treatment. And because they're immune compromised, they are also more likely to get infected. And we also find a new population of dialysis patients who previously did not have kidney disease but may have it as a complication from their COVID disease. I think many of us felt like the vaccine was a light at the end of the tunnel. I remember, you know, just whooping it up with healthcare workers and cheering that finally it seemed like we were at the end of this pandemic. Right now in the United States, we have more than 100 million adults that have been vaccinated, which is just tremendous. But to put it in perspective, that is only about 14% of the United States population. So it's a huge number, but only about 14% of the population are fully vaccinated, so they've had 2 doses of vaccine. When we're looking at the elderly, less than half of them have been fully vaccinated. So we still have a long way to go. We also have limited access to vaccines. So, of course, our priority group is healthcare personnel, people who live in long-term care facilities, the extreme elderly, anybody who works with the public. We also have some priority groups for those who are younger but have an underlying medical condition that puts them at risk of serious COVID disease. And I think it's important to note, though, that a lot of jurisdictions have started opening the vaccine up to anybody. So that's important. At the time I wrote this, which was just a couple weeks ago, that wasn't very common. But now we're seeing more jurisdictions that are in that category. But remember that we still do not have a vaccine for children. Children are a significant portion of our population. The data so far supports that children don't get quite as sick as adults, but certainly we have had children that have been seriously ill and even died from COVID, so they are by no means safe from this virus. So until we are able to vaccinate children, you know, we're going to have a significant portion that are at risk. We also have a pretty significant portion of the population that are what we call vaccine hesitant. So these folks are unlikely or outright refuse to be vaccinated. And then we also have a portion of our population who have a contraindication, so who will never be able to be vaccinated. So unfortunately, we have seen some variants that have emerged from this SARS-CoV-2. We're up to 15 or 16, I believe. Just last week, the CDC and the World Health Organization developed a classification system where they consider a variant to be under investigation, of interest, or of concern. Right now, we have 5 variants that are of concern. They've all been identified in the United States. Luckily, not too prevalent, but that could easily happen, especially considering they all have the ability to evade our vaccine. So our vaccine is only moderately effective against the variants, and all of them are more contagious. So one of the risks I think that we run into when we talk about starting our vaccination is reopening too early. This is kind of one of those hot topics. I think we hear a lot of politicians kind of talk about reopening. In Europe, this is a strategy that they took. So they tried to, quote unquote, reopen. They relaxed their restrictions. And, you know, around that same time, we started to have a big decline in cases. We saw this globally. And Europe has started to see a resurgence. And this is also about the time that the variant strain became prevalent. It's now dominant in many of the European countries, including France, Germany, Italy. If you remember at the beginning of the pandemic, those are also the places that had some of the highest death burden. These cases do appear more contagious, they appear more deadly, and again, we don't know if the vaccine is effective. The cases in the U.S. are still declining, but it's slowing. We had a pretty steep decline at the beginning of the year, but it's important to know that throughout this whole pandemic, we've been a couple of weeks behind Europe. So it seems like what happens in Europe, we can predict will happen in the United States about 2 weeks later. So this is one of the concerns about reopening too early, is that we're going to start to see these variants become more prevalent, and we're going to have another sort of uptick in cases of these really contagious variants. Oops, I'm sorry. So I want to talk a little bit about vaccine hesitancy because it's really important, not only in the context of COVID, but I think in public health overall. Excuse me a minute. I think I zoomed in. I just want to zoom out. Sorry. So it's a really important in the terms of public health because we've seen that one disease that's been completely eradicated, that was smallpox. We've had a couple that have come close to eradication, which is like polio. And then now we start to see people that on this vaccine hesitancy continuum that were starting to move towards the left. And they were starting to refuse more and more vaccines or become selective about what vaccines they would allow in themselves or their children. And now we've seen a resurgence in, for instance, measles. And it's not any less true with COVID. We have some people that are just outright going to refuse to accept the vaccine. We have some folks that demanded the vaccine. They were, you know, right in line first thing Monday morning as soon as we opened our vaccine clinic. But we have a significant portion of the population that falls somewhere in the middle. So these are folks that will probably take the vaccine, but they have like a wait-and-see approach. They have some questions. Maybe they want more people to be vaccinated first. Maybe they have a preference about which brand they'll take. So these are the folks that we're really targeting with our vaccine messages. It's really important to understand, too, that vaccine hesitancy is prevalent in healthcare workers. We find that about 1 out of 3 healthcare workers are somewhere in that either refusal or the passive acceptance of vaccines. That's really startling because these are folks who are trained and understand science. And if they're vaccine hesitant, you know, what is it like to be for the general population who might be a little bit more science literate? A survey that was done about 6 months ago found that although 2/3 of the nursing personnel who was surveyed was confident that the vaccine would be safe, only about half of them were willing to receive the vaccine at the time. And the CDC found that about 2/3 of the providers that they surveyed were willing to get a vaccine. So that's a significant portion. I suspect that since that time, these numbers have risen because we find in our vaccine clinics that most of our staff are willing to take the vaccine, and I think that's true in our region overall. I'm in the Washington, D.C. area. But it's really important to talk about, when we're talking about vaccine hesitancy, to talk about Black Americans. Black Americans suffer from the side effects of COVID from death or debility disproportionately from other U.S. Populations. It's really startling that their life expectancy decreased by 2.7 years just from COVID compared to 1 year for other racial groups. And we know that Black Americans suffer from kidney disease at a significantly higher rate than most other groups. So many of your patients are likely to be Black Americans, and we find that they are also vaccine hesitant. I have a chart here from the Pew Research Center, but you can see that compared to Caucasian Americans, they're much less likely to both trust the science behind vaccine and accept a vaccine. So this is one target population where it's really important to really try to make sure that they are willing to accept a vaccine, because they're more likely to have those really serious side effects or even death from COVID. So vaccine hesitancy typically is typically one of three factors, or even all three factors, which are called the 3 C's. So we have confidence, complacency, and convenience. Confidence deals with trust. There's a lot of misinformation out there. If you go to Twitter, Facebook, and any of those social media sites, you'll see a lot of quote unquote articles about how these vaccines will change your DNA, or how they're made with aborted fetal cells, or some kind of misinformation that fuels vaccine hesitancy. We also have historical discrimination and racism in the medical system. So this likely fuels some vaccine hesitancy that we might see with persons of color. Complacency deals with the belief that the risk of COVID is very low, or that the side effect from the vaccine is worse than having the disease itself. And then we have convenience factors. So this is how easy it is to get the vaccine and how expensive the vaccine is. We've made some headway here because the vaccine is free for most people in the United States. It's also relatively easy to get depending on where you are. My understanding is some states it's really, really difficult, or some people, the way they have their scheduling systems, it's really hard. But other areas, like in my area, we have drive-through vaccine clinics, and people can get in and out and get appointments pretty easily. So this is going to vary, of course, state by state. The good news, I think, with these factors, though, is if they're addressed, is that it is possible to move people along that vaccine continuum towards the right, towards where they will accept the vaccine. So I'm going to talk a little bit about behavior response, because that's really the crux of all of this that we're talking about today, is human behavior and how we respond to a crisis such as a pandemic. This is kind of the continuum of human behavior. So you have over on the left people that panic, that overreact, right? We saw this with stockpiling, buying all the toilet paper, people that were disinfecting their cardboard grocery packages. This also happens with lawmakers. We see some lawmakers who completely overreacted and shut everything down, and it led to economic collapse. And so this can be equally as bad with policies. And then you have people around the right, and this is the underreact crowd. This is the it won't happen to me, it's not that bad, it's a hoax. And the danger over here is that this can hasten the spread of COVID, and it can also cause a collapse of the healthcare system if we are just inundated with COVID patients. So where we like to keep people is somewhere in the middle, is a rational response. So this diagram is kind of a model that I put together to try to explain what we call the description experience gap. And whenever you have a rare event like a pandemic and you describe the risk to people, most of the time they're going to describe back to you a rational response. They're going to say, oh, that's a risk, I'm going to act rationally in response. But as people gain experience over time, they start to believe or behave as though it won't happen to them. So they start to move right on this continuum. And this is where we start to have like reckless behavior. The problem with that is that sometimes there's a payoff from reckless behavior. So either you gain more time, you gain more freedom. Maybe you can see your grandma that you haven't seen. You know, people are taking reckless moves because they sort of underweigh that rare event as time goes on. It's important to know, too, that this behavior can be contagious. You know, at first, when everybody was super, super careful, you know, we didn't know that many people that have had COVID, but as time goes on and you start to see people that have taken shortcuts and they're not getting COVID either, and you start to think, oh, geez, am I overreacting? Am I doing too much? Is this really not that big a deal? Or I've known people and they've all recovered. It's not that big a deal. So it's important to know that this behavior is contagious. So now we're at a place where we have something called pandemic fatigue. And this is where people are just plain tired of the pandemic. They are tired of these dire circumstances that are dragging on. They're tired of the different lifestyle and the fatigue that just goes along with that. And this is also exacerbated by a false sense of security from hopeful events such as the vaccine. And I am in no way trying to say the vaccine is a bad thing. I'm just saying that it's kind of led some people to feel like that's it, we're done, and you know, they're ready to get back to normal. People become desensitized to risk as they're exposed to it, and it starts to get to the point where the costs outweigh the risk. Right? We've all had costs associated with this pandemic, and you know, it's going to reach a point for a lot of people if they've had, you know, they haven't worked in a long time, or they haven't seen their elderly parents in a long time, where that is going to start to outweigh any risks that they feel from the virus. We also have circumstances that become normalized, right? This becomes normal. How many times have you heard somebody say the new normal? So at the end result of that is that the risk becomes accepted, even though it's preventable. We start to accept it, also called complacency. So I think a really good example of complacency is Captain Edward Smith. If you're unfamiliar with him, he was in charge of the Titanic during its maiden voyage across the Atlantic. He was a very decorated officer. He had piloted hundreds of ships. And he had this, they interviewed him shortly before the Titanic set sail, and this was his quote. He said he had never seen any kind of event. He had never been in an accident. He had never heard of an accident. He had never seen an accident. And during that same interview, he also said that he could not imagine any condition that would cause the ship to flounder. And so, of course, after they set sail, they were at sea for a couple of days, and they started to receive warnings about ice. And he underweighed the risk. He had never had any experience where the risk turned out to be anything, and so they didn't even slow the ship down. They just kept barreling towards the United States, and of course, we all know that you know, the ship sank and thousands of people died, including Captain Smith. So I just want to talk a little bit about complacency culture. We do live in a complacency culture. When I was describing earlier how people respond to the pandemic, the thing that instantly comes to mind is how people react to flu. A lot of people think that flu is no big deal, think it's a cold, don't get the flu vaccine, even though we know it kills thousands of people every year. We've ventured into complacency. Also think about it when you're driving. When you're a new driver, you've got two hands on the wheel, you're very careful. If you're driving someplace new, you're very careful, you drive the speed limit. But as time goes on and you become used to your route and, you know, you've driven 10 or 20 years and you've never been pulled over and, you know, speeding becomes normal, you become a little bit complacent. Maybe you text message while you drive and you've never had an accident before, so that becomes more and more accepted. And I also think about weather events. I have a brother who lives on the coast of South Carolina, and when he first moved there and there was a hurricane, he would drive to Atlanta because he wanted to get out of the path of the hurricane. And then after a few hurricane seasons, he stopped doing that, and he just started staying home. And I don't even think he boarded up his windows or did anything special. because he had just become so used to the risk that it was acceptable. So let's talk a little bit about why it's hard to stick with precautions, right? The recommendations have changed a lot. It's hard to keep up with. Some things we were doing last week we aren't doing anymore, and so then we start to think, is any of this even effective? Also, it's really difficult to have sustained behavior change. Anybody who's tried to diet or quit smoking knows how difficult that is. Again, the risk, especially over time, may start to seem less real, and maybe we get some kind of thrill from reckless behavior, either no consequences, you know, oh, I went out without a mask and I didn't get COVID, or oh, I went and visited my grandparents and nothing happened. So you get some kind of benefit from that reckless behavior. So we start to think about that behavior using, I like this model for behavior change. It's the Combi model. So it looks at our capabilities, our opportunities, our motivation, and our protective behavior. And so when we're talking in terms of COVID, surveys show most people have a really high level of knowledge related to COVID. We know how COVID spreads. We know how to protect ourselves. Everybody knows to wear a mask, to wash their hands, to disinfect surfaces. But eventually, emotion and contextual factors can have a greater impact on behavior than knowledge. So that's where we are now. We're to this point where fatigue is starting to kind of overwhelm our motivation to take those protective behaviors related to COVID. Education alone is probably not enough to overcome this. We have to focus on re-motivating people. So I'm going to talk a little bit about that when we talk about policies. So we're looking at, with a demotivated population, that the policies that are in place are gentle and that people are incentivized to follow them. Harsh policies are effective in the short term, but they violate the rights of individuals and they are not consistent with democratic principles, right? On the opposite end of the spectrum, we have too liberal policies, and these are reckless. This can lead to tremendous spread of disease, and you know, I think about some of the states or countries that have fully relaxed their COVID precautions and what's happened there. So we don't want that. We want rule enforcement, but we want it to be gentle. So the key is to make responsible behavior, minimize the effort, but make the payoff worth it, right? So I think about some of the recommendations that have come out, say, from the CDC. So recently the CDC gave us some guidance on how we can start to socialize again with other people who are vaccinated or family members who live close to us who are vaccinated, who are at low risk, depending on households. I mean, there's guidance on there about how we can still, you know, live our life in a gentle kind of protective way. Also in the area where I live, we used to not be able to come to work in Washington, D.C. if we had traveled outside the area for any reason other than that we absolutely had to. So we would have to quarantine and get tests. And now if we're vaccinated, we can travel. We don't have to quarantine when we come home. So, you know, again, this is some, you know, gentle relaxation of the rules while keeping those protective behaviors in place. So how do we create gentle policies? One of the key strategies is understanding people, understanding who's experiencing demotivation and what will re-motivate them. We also want to understand which groups are experiencing increased transmission and target our interventions towards those groups. We also have to understand that, that there's a lot of information out there, and a lot of it is misinformation. So we really need to take what is learned and kind of combat those emerging perceptions as we find them. It's also important to acknowledge hardships. The pandemic has been hard on everybody. You know, my partner works from home, my kids are home all the time, and you know, it's loud, it's really difficult to get work done. And a lot of people are experiencing this. A lot of people are out of work. So it's really important to understand what will motivate people to keep those protective behaviors in place. Another key strategy is engaging people in the solution. Humans have a need to feel in control. So I have a little quote down here that I think kind of really explains this, but we control the pandemic with our behaviors, right? It is known that human behavior how we responded to the vaccine will either precipitate the spread or it will control the spread. And so we need to factor that in when we're looking at how best to implement policies. We want to include the people, include your staff, include your patients in those efforts. Also look to positive deviance. Positive deviance we use a lot when we're talking about some other infection control initiatives, but this is where people have developed kind of a novel solution to a problem, and it can start to kind of become enculturated within your population. The people who do the work, the people who are at the front lines are the ones who really understand what the needs are and what will work. So listen to them. And it's really important to know also that people are more likely to listen to information if it matters to them. So this is where stories come into play, telling a story to help illustrate your point. Another key strategy is allowing people to live their lives but with reduced risk. So this is where we shift the message from do not to do differently. So think in terms of harm reduction. This has been really effective when we talk about STD reduction. So instead of telling people don't have sex, we tell people use condoms, right, to harm reduction. I think that we're starting to see this come out from some of our public health agencies with how we can sort of get back to normal with harm reduction. So if you're vaccinated and your population is low risk, you can start to do some of those things that we miss. It's also really important to work on habits. Complacency can lead to behavior defaults or like kind of what we consider like a autopilot. How many times have you driven to work or driven home and you don't even remember how you got there? You know you got in your car, but you don't really remember the route. This happens to me all the time. Set some visual reminders, maybe put a mask by your door or some other way to remind people to wear a mask or to wash their hands as they're coming into your unit. Role modeling is really important. So the leaders on the unit, your physicians on the unit should definitely be role modeling correct behavior. And then pay attention to close calls. So if you have somebody who for some reason didn't wear a mask, forgot to wear the mask, something like that, find out what is driving that behavior so that you can fix that. And again, positive deviance. Look to those folks who have solved the problem on the front line and try to enculturate that into the rest of your units. So to sum it up, we are really trying to reinvigorate vigilance. We're trying to make sure that people stay committed to getting this pandemic under control before we are at a point where we have like herd immunity or before we're at a point where it's safe to relax. So include everybody. Make a commitment to each other, make a commitment to your units to keep each other safe. Stay flexible because recommendations are going to change. It doesn't mean that the recommendations that are in place now are not effective. It just means that we're learning more. Keep practicing precautions until they are habits. Keep your supplies handy. Make it easy to do the right things. You should have hand hygiene supplies, masks easily available in your waiting rooms, in your dialysis units, where people can easily get them. Use stories to help engage people to understand the risk and the consequences. And importantly, give choices where you can give choices. We don't have to be unnecessarily harsh. So it ain't over. We are not at the end. We might be seeing a light way down at the end of the tunnel, but we are not near the end yet. I have a bunny here. It kind of symbolized, I guess, Easter. We're definitely going to be still in our pandemic for Easter, probably through spring, maybe even through summer. So it's really important to continue to screen and test patients. Remember that we don't know yet how effective the vaccine is, both beyond 90 days or against the variants. So vaccination is not 100% effective. It does not mean that that person is not at risk of acquiring COVID or transmitting COVID. Remember to social distance during breaks. That's still really important to keep that 6 feet distance between you and the people you work with. We see a lot of transmission in waiting rooms and in break rooms. I think especially in break rooms because people kind of feel like they can let down their guard. They're eating, they're hanging out with people they work with every day. Performing hand hygiene, disinfecting those surfaces, and really important, if you feel sick, stay home. And that is the end of my presentation. Does anybody have any questions?
Well, thank you, Dr. Millson. There has been some questions that came in through the chat. I just want to remind everybody, though, if you do have questions, it's not too late to go ahead. Please submit them. We have some time here that we can probably get through most of them. So just submit it through the chat or the Q&A. So I'll go ahead and ask a couple that did come in. Well, one's a comment I'll start out with, which it says, this was Catherine says, she'll be using the Titanic story this afternoon explanation. So I do think that was a great story. And I mean, I think because we all know the Titanic, I mean, movie's been made about it, so it carries on, the legend kind of carries on in the story. So I think people can really relate to that. And that's a really classic story of complacency. So yeah, thank you for sharing. A great that's great. So one question, another question. Can a transplant patient already fully vaccinated and with antibodies present take a short plane trip to visit family and feel safe, or should they still postpone traveling?
I would say for now to postpone travel. And the reason why is the post-transplant patient, of course, is immune suppressed, and we don't know the effectiveness of the vaccine against variants. When you're within kind of your own group at home, we can kind of predict the strains, the prevalent strains, or we know the prevalent strains. But if they're traveling to someplace unknown, there might be one of those variant strains, and which is going to put them both at higher risk for acquiring the disease and then having those severe outcomes.
Okay. Great. A question, speaking of variants, that really goes into my next question. How are these variant strains identified?
So they get sent to the CDC. If we believe that the case that we're seeing is a variant strain, for instance, if it's somebody who's been COVID positive before and now they're sick again, or they've been vaccinated, or we just have a really weird outbreak. We had an outbreak in our hospital. And so we ended up sending all of the isolates to the CDC to see if it was a variant strain. So not every swab is going to get sent to the CDC, so this might actually underestimate the prevalence of our variants, but it's important to know that it is out there. And, if we look to Europe, we can expect that it will increase if we don't keep vigilant about our protective behaviors.
Right. Thank you. So, and do you know, Dr. Millson, has there been information out there yet? I mean, do we know that the current COVID vaccines that are out there are good against these variants, or do we know?
So the CDC, the CDC and the World Health Organization, just recently when they were describing their variants of concern, there's 5 of them of concern right now, they say that the vaccine is moderately effective. So I don't know quantitatively what that means, what percentage exposed will end up getting the disease, but we can presume, a pretty high percentage, maybe in the neighborhood of 30 or 40%, if they're vaccinated and exposed, will get the disease.
Okay, right. Thank you. A question, I think it was back to earlier slide about for sure we know that you were protected for the 90 days after the vaccination. So the question was, does this mean that we'll need another booster after 90 days or become an annual vaccine like the flu?
So that I wish I knew the answer to. I myself don't know the answer to that. My 90 days expires on April 11th, and I have Billy Joel tickets on April 17th, and I don't think I can go because I don't know the answer to that yet. Everybody that I've consulted in public health or my colleagues in infection control, nobody knows the answer to that. All we know is the studies so far tell us that there is immunity for 90 days. We don't know beyond that. As to whether it'll become a yearly vaccine, I think that depends on how quickly we can get our current outbreak under control. If we can get that under control relatively rapidly before we start having a lot of variants, then it's possible this will kind of be a one-and-done situation. If we start to have these variants that develop and circulate, then we might end up like the influenza, where we have to get a shot every year. It's too early to say.
Yeah, good. Yeah, thank you. Kind of back, another question, I think was a follow-up to the first one about how are the variants identified. He also wants to know what are the symptoms of the variant. So what makes you suspect that it could be a variant when you see a case in the hospital?
Yeah, so it usually has to do with either the contagiousness or just the symptomology. It's just weird. It's either more severe or a lot more cases of it, or like I mentioned, we'll see it in a population where we wouldn't normally see an infection. So in somebody who was previously positive or somebody who's already been vaccinated. That would lead us to believe that it might be a variant.
Okay, all right. Good. Another question. Should dialysis patients be concerned about when to get the COVID vaccine based on when their next treatment is? Basically, do we know if the vaccine can dialyze out?
That's a really great question. I don't believe so. I don't think I've ever heard of vaccines, dialyzing out because it's not in the blood. It's in the, it's in the tissue, and your immune system responds to it in the tissue. But I am not an expert in immunizations in that way, so I don't know the answer to that. But I don't think so. I've never heard of that with any of the other vaccines.
Right. Okay. Good. Thank you. So there's, so much information circulating out there about COVID and the vaccine, TV, social media. You turn the TV on, that's all you hear. How does, to help this complacency, how does one filter out all this information? What sources can they trust?
Yeah, that's a great question. I think especially as time goes on, those lines start to blur a little bit as we start to see some of the sources become, amplified by people we know. Then we start to see them as trusted sources. For the dialysis population or the medical community in general, I would suggest sticking to those tried and true sources. So the CDC, the National Kidney Foundation, your own local public health departments are the best place to get information. Any kind of medical professional society like the ASN, APIC, which is infection control, are good places to get information. Bad places to get information is probably most of what we see on Facebook or social media, or even some of the news articles. Those can also kind of amplify those misinformation. So I would stick to the tried and true medical sources.
Okay, right, agreed. A lot of social media out there, it's hard to decipher what's accurate and what's not. So it kind of going back to I think the hesitancy, do people have an option to which vaccine they receive? Such now, I've heard a lot of people, myself, I'm waiting till the Johnson & Johnson one-shot vaccination comes out. I mean, how much of that, can the people pick and choose, or at this stage?
That's a great question. That is probably going to vary by jurisdiction. I know here locally, and even in our hospital, we had, the Pfizer available, so that's what everybody got. But other hospitals would have, the other available, and that's what their staff got. So I think it depends on where people go. I think if you go to your pharmacy or your physician or even your vaccine clinic, you're probably not going to have a choice at this point. It's going to largely depend on what's available.
Mm-hmm. Yeah. Um, Thank you for that. Yeah, it's I mean, it's nice to get one shot, obviously, but I don't know at this point we do all have the option yet. So again, back to your beginning about what the percent of healthcare workers have taken the vaccination. How much do you think that plays in as when you're trying to talk to your patients who are vaccine hesitant? I mean, how often do you think they're asking the nurse or the nurse's aide, one of the first questions of, well, have you gotten it? I kind of like the doctor, have you gotten your vaccine yet? And they're saying, I wonder what do you think they're being said? I mean, how do you convince somebody if you have not taken that vaccine yourself, who's vaccine hesitant?
Absolutely. This is a big concern that we have because, like you said, is that nurse or physician who's vaccine hesitant, are they advocating for their patients to get the vaccine, or are they, spreading misinformation? So that's a really important thing to think about because our patients look up to us. They trust us. I think, especially in the case of dialysis patients where we have these long-standing relationships, we know them for long periods of time. We spend a lot of time with them. And they really trust us. So it's important to, if you do have somebody who's vaccine hesitant, they should not be the person who is talking about vaccination with patients. And I would suggest having some kind of literature maybe available that they could give instead of having that conversation. I would never tell anybody to lie to a patient, but yeah, I wouldn't have them sharing their hesitancy, whatever the reasons are, because patients are going to trust them. And if they say, I don't trust the science or the vaccine was rushed, their patient is going to believe them.
Yeah, true. I'm glad you mentioned that about some resources. Is there any one that you know of, Dr. Millson, that has maybe some good tips on or to discuss, talking points, if you will, about vaccine hesitancy with patients? Is there anything out there that comes to mind that's a really good source?
Definitely the CDC has some great resources. Also, the ASN has some great resources on their website as well.
Okay, good. Because that's important. I haven't seen a whole lot of that, any articles or literature or resources about that too much. So, but yet we talk about it.
Remember, vaccine hesitancy is not unique to COVID, so you might have to look at vaccines in general because we find vaccine hesitancy a lot with flu vaccines as well. Yeah, so it might just take a bit of searching or looking a little more broadly than COVID.
Okay. Yes, thank you. Yeah, and you're right. We've worked in the dialysis facilities for many years. Just trying to get our patients to get a flu vaccine was very difficult. So I can't imagine how they're struggling with it now with the COVID. So another question. I think we have maybe time for one more. How long should a recovered COVID patient wait to get the vaccine?
So they say 90 days because you have protective antibodies already from the disease. So if you wait 90 days, it'll be like a booster. Like you have protective antibodies from when you had the illness and recovered, if that makes sense. So.
But they're still recommended the 2 vaccines then, if it was a Pfizer or Moderna? Yeah, okay. Good. That should hopefully answer that question. And how do patients, dialysis patients, I'll specifically verify that they are on dialysis, or if they're under 65 and have underlying medical conditions so that they can get the COVID vaccine?
To my knowledge, that is just self-reported. That they don't have to verify. There's nobody's going to call and check. You don't have to bring anything.
So they can just sign up and say they are, or they have some underlying medical conditions, and they're accepted.
Yeah.
Okay. Well, I don't think I see anything else. Anything, Dr. Millson, you just want to maybe, any last recommendations, tips, any good resources on COVID complacency out there if people want more information where they should look?
Well, I think this is kind of a new phenomenon that we're just starting to see, in probably the past couple of months. But I guess the take-home message really is it's not over. And if we start to relax our protective behaviors now, we're going to just prolong this even further. So if we can just hold on a little bit longer. They've started testing the vaccine in children. I think that by midsummer, we'll start to be able to vaccinate children. And then once we can do that, most of our population will be vaccinated. We'll reach, hopefully, a status of like herd immunity. And then maybe by next Christmas, everything will be back to normal. You'll be at your grandma's and, eating turkey dinner with your relatives. And so that's, I guess the take home is just to keep those behaviors going.
Okay. And there was one last question that came in. I'd like to I'll get through that real quick. I think, if a patient already received one dose of the vaccine and then got COVID in the middle of getting the second, do they still need to wait the 90 days?
Yeah, so that I don't know the answer to. I would defer to their physician for that determination, because that's kind of a unique situation.
Yeah,
I think if they don't get the second dose, they might even have to restart the whole series. But I don't really know the answer. Yeah.
Yeah. Okay. Well, good. Well, thank you so much for sharing everything. I think we got through all the questions. I really appreciate this. It was a very interesting topic, because I do think your timing. I think the timing was really good. Like I said, it's hard to even believe it's been a year, but here we are. And actually, when you started to look back to everything that we have done in the year accomplished, it was like, we did that. We did, this has happened. So it really kind of put it in perspective, I think, for me. For sure, we don't think we've done anything, but yet when you look back, how much we have accomplished, and we're hopefully the next year. But I do agree. I don't think we should let our guard down. I do understand. I think we're still got another year ahead of us here, probably at least to the rest of this year. But Matt, I think you have the ball back. So you do, if you can just move on to the next slide. And just a little bit of a few slides before we close up, I just want to remind everybody the ESRD NCC has a flu vaccination toolkit that's on our website that has a lot of interesting information. It's full of some videos, some print-ready materials. There's on-demand training, educational events, flu facts and taglines if you want to use them. So again, just want to know that it's out there. It's visit esrdncc.org/flu and look into our flu vaccination toolkit. Next slide. And the ESRD NCC has developed a new resource for patients. It's called Pledge for Clean Hands to Keep Each Other Safe. We have it available in English and Spanish. We have it, there's two versions, one for the dialysis patients for in-center, and then for patients who are living at home with maybe extended families, multi-generational families. Again, some tips on when the patient and family and or caregivers or healthcare professionals should be washing their hands, and it's okay to speak up. So if you want to view those resources, you can print them and share them. Again, there's either the QR code right there, or visit esrdncc.org and go to resources, professional, and health associated infections. So next slide. Kidney Learning Hub. It was a mobile-friendly web tool created by patients for patients. There's links to new videos and helpful resources are added all the time. There's things on not just COVID, but there's other information regarding home dialysis or transplant, diet and nutritional resources are added. There's always new information being added and updated to the Kidney Hub. Next slide. Just as a reminder, our next provider focused event is April 7th at 3 p.m. We also have the patient-focused event, April 13th at 4 p.m. And you can find these on our website. That's okay. Visit kidneycovidinfocenter.com to register. And also these are our post events. Any of our post events there, the recording and slide deck is also posted there. And if you didn't, if you got on a little later, I just want to remind everybody, if you stay at the conclusion of this event, if you stay online and you want CEUs, you will be taken to a survey. And after you're completing that survey, if you stay connected, you will then be taken to our learning management system, and you will be able to obtain one CEU for today's event. So please, if you would like to obtain CEUs, just stay connected after we close out the event today. And now the next slide. So again, just thank you to Dr. Millson for taking time out today to be with us, to share this information. A lot of good questions came in, and Dr. Millson, appreciate you being here and working with you and your presentation today.
Thank you. It was great to be here. Thank you.
Thank you. And thank you, everybody, for joining us. Take care, stay safe, and hope that you can join us on a future event. Thank you, everybody.